little background. Mohs surgery is considered the gold standard for certain face, neck, scalp, skin cancers. Mohs is also indicated for other what we consider high-risk areas or areas that require maximum preservation of skin, tissue, nerve function, or cosmetic outcome. And those are key words when you're looking at doing authorizations. Sometimes insurance companies like to see that if it's not a traditional Mohs site. It is considered the gold standard treatment for those skin cancers, and it has an effective cure rate of 99%. So that's why we do Mohs on those areas. The team consists of Dr. Whitaker. He's our board certified Mohs surgeon. A Mohs surgeon is also trained as a pathologist, and we'll get into that in a little bit. We also have all of our medical assistants. We usually like a functioning team of about 5 medical assistants. Our Mohs histotechnologist, she's the person that actually prepares the slides, and we'll talk about that a little more. Myself, I'm pretty much considered doctor's first assist, and then Dr. Whitaker, of course. The roles of the team members, the medical assistants, pretty much do most of the work, the background work.
We are working today on the right frontal scalp for a squamous cell carcinoma. Okay, I'm gonna first get your vitals, make sure they're good. Is it okay if I check your blood pressure on this arm?
Yes.
Yes. All right. Here we go. All right. And any allergies to any medications?
Yeah, a few.
Okay. What are your allergies?
Any of the Cillins,
Okay.
and I think that's it.
Okay. How about to Valium or Xanax?
No.
Any allergies? Okay. All right. So blood pressure is good. So now I'm gonna go get your medication. It's Xanax. So I'll be right back. And get
What's the Xanax for?
the Xanax is to help relax the muscles of your face. It'll help you relax too, because I know a lot of patients are very nervous.
Yeah.
It's a surgery, so
Okay.
that will help you relax.
How long does it last?
It may last until tomorrow. So that's why we
Okay.
had you bring a driver. You cannot drive yourself back. Do you have your driver here?
Yeah, they're waiting for
Okay.
me.
And so once I administer the Xanax, you may lose your equilibrium. So make sure
Okay.
that if you feel dizzy, let us know. We'll wheel you around in a chair,
Okay.
or we can hold you.
Okay, thank you for telling me.
I'll be right back.
Okay.
I'll go log in the Xanax and don't go anywhere. Okay.
Okay.
Okay. So when I'm gonna administer Xanax, it's a narcotic. You want to make sure you put the date, time, the patient's name, and the dose. We administer 1 milligram of the Xanax. So it's all counted. You want to make sure that you have the same amount before you even get the Xanax. So that way, if you're missing one, you check with the supervisor what happened to the other Xanax, and you keep track of it. So once you log everything in, make sure you sign it and have somebody else double check the medication. So now we have the medication ready for the patient, and it's dispersible, so it'll dissolve on the patient's mouth, and it'll act or start acting like in about 20 minutes, maybe less. So you want to make sure the patient is safe, they can walk themselves. If they are dizzy, then you want to wheel them around, or if they feel the effects of the Xanax, you want to make sure they are safe. So I have your Xanax.
Okay.
It'll dissolve under your tongue, and
Okay.
it's fast acting.
Okay.
So make sure you, that when I walk you to the OR, let me know if you feel okay. If you don't,
Okay.
then I'll get a wheelchair.
Okay.
So just go ahead and put it under your tongue. And I'd like to ask you, do you need to use the restroom before I take you to the surgical room?
I'm okay.
You're good? Okay. So let's go ahead. I'm gonna take you to the OR. You feel okay?
I am okay. Go right this way, please.
On the day of surgery, like you saw in the video, there's the intake of patients. Make sure you're taking vital signs, medication administration. When you get to the OR, you actually have to make sure they're positioned properly. You always want a vertical plane versus a horizontal, so doctor wants to be able to work this way rather than up and down. Bedside assisting, you got to be ready for anything, whether we're doing the opening stages or the closing stages. And you'll learn as you work with Dr. Whitaker what he expects of you. And then a big aspect of making Mohs day flow like it should is the turnover of the room. Basically, we do about 15 cases in a day, sometimes more, sometimes less. you have to consider that the patient is in the room twice. So we're looking at 30 actual patients in a room. So that room has to be turned over in a timely manner, cleaned, ready to go. Instruments, there's always instruments to transfer, instruments to get ready for the autoclave. There's always something to do. The drug count has to be very consistent on those days, again, because we have 15 patients coming through the door, so we're giving out 15 medications. The cryogun, we like to have a cryogun in each room. Beth is our histotech, our Mohs tech, and she will use the liquid nitrogen. But a lot of times the patients have had more than one biopsy, and so we're doing the surgery, but they have something else they need treated. So again, to save time, have the cryoc here, so we're not running around looking for it. Prior to surgery, authorizations, those have to be in place before we can do the surgery. These are thousands of dollars worth of surgery that we're doing on these patients, so if it's not authorized, yeah, that's a big issue.
So now that we bring the patient in, everything's pretty much set up. We're going to bring the patient in, and we're going to go ahead and put the grounding pad on the patient. Well, actually, sorry, first we're going to ask the patient to remove any jewelry, any metal. So they're going to remove their glasses, any jewelry they have, anything in their pockets, keys, phone. If they have a big belt buckle, they'll go ahead and remove that. Hearing aids, dentures, the rings, no rings, good, no earrings, very good. And then we'll go ahead and apply the grounding pad. And usually I tell them that this is for the electrocautery, when the doctor has to stop any baby blood vessels from bleeding. This is what will help the patient not feel the shock or the heat. So that's what I tell them. And I remind them that it's very cold once I apply it, but it will warm up. And you can put it on their side or on their arm. So I'm going to do it on the arm. And then I'll just there we go. Sometimes they jump, but I like to warn them. Okay. Now I'm going to go ahead and plug it in over here. Right in there. And then I'll go ahead and turn it on. So next we'll go ahead and position the patient according to the site. She's doing it on the left dorsal hand. So we're going to go ahead and put the feet up first. And I like to tell them what I'm doing so they're kind of aware beforehand. I'll put the back down a little bit. And Dr. Whitaker does not like to have the pillows. So what we usually use are gowns. So we get some gowns and we kind of go ahead and fold them up. And we put them underneath this chucks here so she could be a little more comfortable. How's that feel, okay? Okay. So since it's on the hand, we don't have to put her all the way back. And you'll learn how to position her more as you go along. So let me tilt her back just a little bit more so she can. Okay. So we're going to use this tray so she can put her hand here so the doctor can work on it easily. Okay, so go ahead and put that there. You want to make sure it's at a good height, accessible to the doctor. And then, so that's good. We got to make sure this is stuck on there good. Okay, so, and then we got to make sure the tray is in a good position. So probably here is best. And also at a good height. Then I get the hand switching pen. This is what we use to cauterize the blood vessels. And then we'll go ahead and plug this in into the machine. Okay. And I'm going to go this way and put that on her chest and use the towel clamp to clamp it down. And we want to make sure it's not all tingled because we want the doctor to be able to grab it easily. So we'll do that. And then you're going to take the tip off, just like that, and just lay that there. Okay. our goggles. In this case, we don't really need them because it's going to be, the lights are going to be down here. So now we're going to position the lights. Also, make sure they're good. Dr. Whitaker likes them kind of behind him, like right above him pretty much, but behind him more. So if he's standing here, we're going to need them like this. And then we'll go ahead and turn the lights on and point it down where he's going to be. He usually always moves them, but just in the right vicinity, that would be good. So just make sure there's no shadows. So you see there's no shadows there. Okay, so now we turn that off. We make sure we have everything in order. So also I'm going to label the patient's tray with their name and any allergies that they have. Will be right there. So go ahead and put that here. Okay, because then we'll know whose tray is what. We won't get them switched up. Okay, so now I'm going to go ahead, once everything's done and set up, I'm going to make sure that when the doctor comes in, all the forms are laid out. So we'll have the patient's map. The patient should have these already when they check in. These are their post-op instructions. And then also the consent form. And we usually have pictures and pathology. So we put that all out here, laid out for the doctor to see when he comes in. So we'll do that. And then we'll go ahead and let Darlene know that she's ready for numbing.
My role is pretty much first assist. I do all the anesthesia for the patients. If we're running behind, Dr. Whitaker is not opposed to anesthetizing himself. You just let him know. The bottom line, it's the patient flow. We got to keep going. We can't have empty rooms. We can't have patients waiting. So, you know, if you've got somebody ready and I'm doing a closing, doctor will be more than happy to anesthetize the patient. I also do what we call prepping the opening stages for bandaging. Basically, that's just cauterizing, making sure there's no active bleeding. And when things are good to go, then the medical assistants do the bandaging. Hello, hello! Are you Miss Mouse?
Yes.
Hi, I'm Darlene. I work with Dr. Whitaker, and I'm going to get things nice and numb before he comes in, okay? Make sure you always greet the patient. You know, this is pretty much part of my job. So I come over here and we'll check the pathology. So it looks like we're taking care of that little skin cancer on your left hand. Is that right? Okay. And then sometimes the medical assistants will go ahead and mark the site. If not, then I just verify the site. And it looks like from looking at my pictures, we're going to take care of that little spot right there, correct?
Yes.
Okay. And you're not allergic to any numbing medicines, right? Things like the dentist would use?
No.
Okay. I won't really poke you.
Please don't.
So, okay, you're going to feel a poke and a burn. So we get things nice and numb. Do you have any questions for me?
How long is this going to take?
Well, start to finish, you're usually here anywhere from 2 to 3 hours, sometimes a little longer. So if you are not real clear on what we're going to do, doctor's going to take out a couple little sections right now. I'm going to go get him. And then he goes back, he takes those sections to his lab, they're prepared. He looks at them under the microscope, makes sure all the cancer's gone. If it's not, he comes back in and we do a couple more. And then I come back in and put the pretty stitches in for you. So, okay, you feeling all right? The medication we gave you, do you feel like you need a little more or are you doing well?
I think I'm okay.
Okay, all right. So at this point, I go get Dr. Whitaker. When he comes in, if you have any questions, you can talk to him and then we'll get started. All right? Okay. That brings us to our star, Dr. Whitaker. He is board certified Mohs surgeon, and what a Mohs surgeon is also trained in pathology. So I usually explain to the patients that if you had a large solid tumor in your colon or something, you'd go to the surgery center, they'd take the tumor out, you'd go home. A couple weeks later, you'd get the call that, you know, we got all the cancer, or no, you have to go back. With a Mohs surgeon, we're actually knowing at the time that you're here that we either got it all or we need to do more. And if we need to do more, then we do it right then. He's also trained in several really consistent plastic surgery technique, so his outcomes, we always tell the patients the outcomes are really nice. He does a really good job. He's refined the Mohs technique. He's taught it pretty much worldwide. He's a lecturer across the country. He does Mohs surgery for us. He does Mohs surgery in Tucson and also in the state of Washington. So, and he's written numerous journal articles, textbook chapters, and things like that on Mohs. So we're very fortunate to have him.
Okay, so now that Dr. Whitaker is done with the first sections, we're going to go ahead and take those to the lab to Beth. So we'll grab our Petri dishes, and we can use this tray, and then we're going to grab the map. And the map looks like this, has the patient's name and the site and the type of skin cancer. So we're going to take that right away.
The Mohs tech, her name is Beth, and her job is to prepare the gross tissue sections that we take down. She does frozen sections of those, and those are the sections that doctor actually looks at under the microscope. She's also responsible for giving us the maps. So when doctors looked at the tissue, he's filled out the map, we know what else we need to do. She'll either bring them down herself or she'll give them to one of us, and then we know the patient's ready to go.
So we have received the map. It is saying that we need a stage 4. So we would get another Petri dish ready. Make sure there's a label. Always double check. Patients' labels can get mixed up, so we want to make sure it's label 4 and label what number it is. He can do 4, 5, 6, so always make sure that they're lined up.
And we'll say it right there on the map.
Yeah, so it's 4.
So right there it says 4. We're going to need a 4 Petri dish, so that's why we know number 4.
And once we get the map, you also want to set up the tray, and he will specify what sutures he wants for underneath and then for the top sutures. So you're going to get 4O proline P3 and 4O mono P3. So the sutures should be here in this cabinet, and just pull out 4O P3. You're going to put them on the sterile tray, saline on the sterile tray. Open your tray, sutures, and get your sterile gloves ready. Change your light covers to sterile covers. Have sterile gloves ready for doctor. And at this time, once everything's ready, you have your sterile light covers. Patient is positioned for the 4th section. We'll let Darlene know that patient is ready for renumbing. We don't want the patient to feel any pain, so she'll renumb before Dr. Whitaker gets started for the closure.
And then when he's done with the final sections, we've gone sterile, then I do most of the closing for him, and that's the suturing. So when we're doing that closing, you work most of the time closely with me on the closings. Once in a while, again, if we're just going with patient flow, getting patients in and out in a timely manner, he'll do some closings too. So we do things differently, and you'll learn how to work with each of us, but he will do some closings himself. So now we'll assume that Dr. Whitaker is already finished, and he tells us, okay, we're good to close. There are some instruments that we always transfer to the closing tray. The skin hooks and the hemostats. Doctor will usually tell us if he thinks we're going to need more hemostats or something like that, so we'll know ahead of time for that. So we just transfer those to the closing tray.
Put these on here. And we're also going to fill the bowl up with water too.
Just a little sterile water goes in there.
And usually the doctor will write on the map what sutures they need, but if you need to ask, you can ask, and then they'll let you know and grab them, and also drop them on the sterile tray. So we'll go ahead and do that. And then we'll put a little sterile water in the bowl. Just about halfway is good. Once the doctor, once we're done transferring the tray, we'll go ahead and grab the betadine and betadine the area while doctor is gloving up too. That's good time to do that. So we'll go ahead and start in the middle and then work our way out circular.
When you're doing the betadine scrub, you, like Eden said, you always start in the middle, and each circle should be a little further out, and don't be afraid to do too much. So you can't go too far out. Further is better. You want to start the center of the defect because that's the spot you want most clean. So you start there and work your way out.
Also use this too.
Yeah, and then we also do a little splash that just kind of gets a little deeper inside. At this point, everything becomes sterile, so if you don't, usually we would have our masks on, but for the sake of the microphone, we're not going to wear them. Masks go on, and then my sterile gloves go on, so we'll go ahead and put those on. Again, the masks would be on for this, so.
And then I will also put on sterile gloves because whoever is assisting Darlene or Dr. Whitaker at this time will also glove up sterile. And you gotta make sure that they have the sutures, everything's ready to go because then you don't want to re-glove.
A good thing to ask before you put your gloves on, is there anything else you need? Everything good? That sort of thing. So at this point, if I'm doing the closure by myself, I'll go ahead and drape myself. Sometimes doctor will have you help drape. Never assume he wants you to do that. So just he'll ask you if you need anything. Doctor has the right to change his mind, so no matter how you have the lights, he'll always move them around. So at this point then, we'll make sure that Eden has her instruments that she'll need. She'll need forceps. And she'll need suture scissors. And we'll adjust things here. And at this point, we start suturing. So we put the sutures. Eden, there's certain techniques that you'll learn. There's a technique called catching, and that's where we actually push the needle through the tissue. Eden will catch, she'll pull it through, give it back to me. There's another technique where we do a pinch. And that's similar to if you're trying to tie your shoes, you put that finger down on the first cross. She'll pinch it to make our knot. Don't worry about that. Doctor will tell you if he needs a pinch or not. So, all right, let's go ahead and cut that one out, Eden. And so now, at this point, we would say things are nice and closed up there. And Eden, at this point, Miss Mouse, everything's taken care of. Doctors looked at the slides. All the cancer's gone. We put some pretty little stitches in there for you. And now Eden's going to get things cleaned up, and she's going to put a dressing. We do take a picture before we start the suturing. That's a new thing that Dr. Whitaker has asked. So before I ever start putting stitches in, we'll take a picture of what we call the final defect. That's added to the patient's chart. And then we always give the patient the opportunity to see it when it's clean. So Eden would clean it up, and then we'd say, okay, Miss Mouse, do you want to take a look at this before we put a bandage on? They have the right to say no, that's fine, but we like for them to see what it looks like. Obviously, if it's on the face or something, we have a mirror for them. And then Eden dresses it up. Let's go ahead and put a nice dressing on there. Eden will tell you when you need to come back. All your instructions are in your little goodie bag. Make sure you ice it, keep it elevated. And if you have any questions, give us a call.
Okay.
Anything else I can do for you?
I think that's all. Thank you.
Okay, you're welcome. So Eden, she's all yours.
All right, thank you, Darlene. Okay, so now I'm gonna go ahead and clean the area using the sterile water. And go ahead and just scrub that out. And so you really want to, make sure that you don't lift anything too heavy. You don't want to put any strain on the stitches for at least 2 weeks while they're in. And then the instructions we gave you, did you go over those yet?
No.
No? Okay. I'll go ahead and let you know how to take care of the area. So I'm gonna put some bacitracin antibiotic ointment on here, and a bandage. And what you'll do is just keep the bandage on and keep it dry for 24 hours. After the 24 hours, then you'll take the bandage off, wash the area with warm soapy water, and then apply your ointment and then a fresh Band-Aid.
Okay.
And you'll do that every day for a week. Okay, so I'm gonna go ahead and bandage now. So I grab my goodies, I got my scissors, I got my bandage, I've got my ointment. I'll go ahead and lather this up. We usually have CTAs on the tray, depending on, well, usually for the face and the neck and ear, we'll have the CTAs on the tray. If not, we can grab them on the counter over there and use that to spread the ointment on. I like to do that. And then we'll grab a good pressure bandage. So you want a lot of gauze, and you want to pretty much fold it in half so so it's thick. Okay. And then we like to use the HipaFix for the bandage. So when they leave, they're gonna have to leave it on for 24 hours. So this bandage is the best. It will stay pretty long time. Okay, so that's pretty good. The bigger, the better. So we got that. So I'm gonna need a little bit more on this side. Okay. So you're gonna go ahead and leave that on and then change it every day. Okay. Okay, so at this point we're gonna go ahead and clean up. We're gonna remove the patient from the table and turn off the lights, take your gloves off. Okay, so we'll go ahead and turn off the cautery first, the machine. Unplug. And then take everything off of the patient. Excuse me. And do you have your driver here?
Yeah.
Yes? Okay. We're going to let Kathy know. Well, actually, they're here, so we'll let them know that you're ready to go, okay? Alright, and then we're going to take this grounding pad off. Sorry.
It's okay.
Alright. Okay, and then we'll go ahead and bring you down. Sit it down first, because sometimes they're loopy from the medication, so you want to go ahead and pull down so it's not too high for them. They might fall off. You don't want that to happen. And sit down, feet down. And at this time, they've been laying for a while. They're going to be a little loopy, like I said. So, usually I ask, how are you feeling? They don't know yet, because once they get up, they'll know. So usually I like to have a wheelchair handy, just in case. But at this time, you can go ahead and slowly get up. I'll go ahead and hold you. Good, how are you feeling?
I'm okay.
Good, okay. So we're going to come over here, and I like to hold on to their arm because they're swaying. Okay, you can go ahead and grab your instructions. And let me get your goodie bag, just a second. So you also grab a goodie bag. It has ointment, has the bacitracin ointment in it. And we always grab the leftovers from the tray that are clean. So the clean gauze that we did not use, we put in her bag. And then we ask, do you have bandages at home? If not, we'll go ahead and give them some bandages. So I like to give them a roll of some HipaFix, not the whole thing, but just cut them a little roll, and then they can use that for the first week bandaging. That will really help. Okay, so you got your instructions. Make sure you get your belongings. Don't want to forget anything. And then they already have their appointment for their 2-week suture removal and their 3-month follow-up, their post-op. They're going to have that Kathy gives them when they check in. Okay, so you have your goodie bag, your instructions, everything. Okay, so now I'm going to go ahead and walk you out. Okay. Over here. Easy.
You got a little idea from the video of kind of a typical patient. I did say we average about 15 cases per day. Some of those are actually double sites, and so what that means is we have 2 separate skin cancers that we're taking care of on the same patient. You'll always know going in if it's going to be a double site or not, and those are 2 separate surgeries. They're treated as such. So, our day starts at 7 o'clock. Patients start getting here at 7:30. We're ready to roll by 8 o'clock. The goal is to always have the 3 ORs loaded in a timely manner. So we never want downtime where patients are waiting and the rooms are ready, but we don't have patients back here. So patient flow is utmost. A big issue is the patient needs to be perfectly positioned and ready to go when we tell doctor we're ready for him. His time is very valuable, so if he comes in and the patient still doesn't have a grounding pad on, that takes up valuable time for him. We saw in the video we want lighting with no shadows. I mentioned vertical planes versus horizontal, so if we're working on the hand, doctor wants to work this way. Obviously he doesn't want to have to work this way. And so different positioning techniques you'll learn. You'll learn what works for him, you'll learn what works for the patient. Above all, patient comfort trumps everything else. So if they have a bad back and they're not able to lie on their side, we just work with them and we explain to doctor that's why. So patient comfort is number 1. He makes sure the grounding pad is ready to go for the Bovie, the cautery unit. Always test it, push the button, make sure that it's ready to go. Nothing more frustrating than doctor coming in and needing to cauterize or cut something and it malfunctioned. That's a time saver there. Proper table height. Doctor and I'm a little taller than he is, so we'll always change the table around, but you never want, and for the medical assistants too, you never want to be working down this way. You want to have a plane here with the patient, so head straight and forward, not down. And then something new that we've started is taking pictures of what we call the final defect. So before it's time to put the stitches in, once we get that sterile tray ready, that's a good time to take a picture of that, the final site. Doctor uses that for reference. We can sometimes go back and use it for insurance if they come back and maybe deny a claim for size or something. We can pull that up. Always get the measuring tape in there too, so we get the final defect and then the size. Sterile technique is very important, and if you don't know how to do sterile technique, then you need to learn. And there will be a little thing at the end here where we go over sterile technique. Mainly that's making sure you don't reach across the sterile field. Practice donning your sterile gloves. There's little tricks to that. Don't be afraid to take gloves home. Practice.
So sterile gloves. Always make sure you have the correct size. You don't want to go too big because you want to make sure to grasp instruments and you can get injured if you have your gloves too large. You want to make sure they're perfect. So the way to put them on, open this to the side. And I'm left-handed, so I'll have to do different, but as long as you don't touch the sterile glove, that's all you need. So I'm going to start with my right. Hold them for you here. Put your hand in there, and then pull. Make sure you don't have any jewelry, no watches or rings, because that can puncture the glove and it will not be sterile. The next one will be, hold it from this side, put your hand in there, and then just pull from here, and you're sterile. So once you're sterile, try not to touch anything below your waist, because that will not be a sterile. And then once you're here, you always want to have your hands up. You can't touch anything unsterile, just the tray. And then once you're heading to your tray, this is the sterile field, so you can lift from here and kind of get rid of it or you can do it before. And once you're with your sterile fields, the patient is sterile, you can get the sutures ready for Dr. Whitaker. So kind of get it ready, pull the suture out, and put it back in there. That way there's no injuries. And just once you're ready to assist Dr. Whitaker, your instruments will be scissors and your forceps with no teeth. So I'm left-handed again, so I hold my instruments different. You may want to switch them differently. The scissors, I put them on the ring finger, and then when you're not assisting and cutting, you kind of want to hold or hide your scissors to the side. So, and when you're ready to use them, you pull them with your thumb and hold the scissors so that it can guide you and cut. As soon as you're done, you want to hide them again so that you don't stab doctor or patient, because sometimes they may move the arms or want to scratch their head, and you have your scissors out ready. So always be careful where you have your scissors positioned. Forceps also, you can also kind of hide them to the side, or if you have your thumb on your finger, that will protect the tip of it. So always be aware of where you have your instruments. The patient may be sleeping and then just kind of all of a sudden wake up and move around, so always be careful with that. When you're assisting doctor with any bleeding, you don't want to grab a lot of gauze, because this is going to prevent you from helping. One gauze, and when you dab, then you're just going to do this and move rapidly out of the way so he can continue.
Personal wise, we prefer on surgery days dark colored scrubs. Things get messy, betadine, blood, fluids, that sort of thing, and we don't have the luxury of being able to change in between patients, so we want to present a professional appearance so it doesn't show up as much on the dark. We want to do hair coverings. Everything needs to be tucked in. And also try not to wear any jewelry that might accidentally land in the sterile field. So just make it a habit of no earrings, no big rings, bracelets, that sort of thing. And then make sure you're scrubbing, at the beginning of the day. Do a good hand scrub. We don't necessarily require a sterile scrub, but just make sure you're scrubbing your hands. The standard short nails, that sort of thing. When we do Mohs, we do things a little different than a standard surgery if you went into an OR at the hospital. We start with a clean field. So those first initial stages that Dr. Whitaker does, skin is considered just clean. We get it as clean as we can. And so the first time you see that happening, you may have a little issue. Oh wait, he's cutting, that's not sterile. But the first stages are clean, and then we switch out to sterile. Always before you ever get me into the room to do the anesthetizing for the first round, we want a nice Hibiclens wash on there. It doesn't have to be harsh, you just do a little Hibiclens, scrub, just like you were washing a cut or something. Some people are allergic to the Hibiclens, so that might be something to ask them. If they are, then we'll just do a little alcohol scrub. The final stages, so as you saw in the video, when doctor comes back into the room, he says we need to do 2 more stages. Those are clean, you work off the clean tray. And then as soon as he says he's ready to go, he's got all the stages he needs, then we switch out to the sterile tray. At that point, like in the video, that's when you betadine. More is better with the betadine, so you start in the center of the defect, work out, that was clear in the video, and don't be afraid to do too much. You can't do too much betadine. Bandaging, the girls kind of went over that. After the opening stages, it's just a nice pressure dressing. It doesn't have to look real pretty. And then the final, when they're ready to go home, make sure you offer to let them look at their sutures, what it looks like. We generally try to explain certain sites on the body bruise and swell more, so we kind of go over that with them, what to expect the next few days. Also, never be afraid to take a picture of that before you put the bandage on, so things are nice and closed, the stitches are in, cleaned up nicely. we'll never get upset if you want to take a picture of that. Sometimes that's nice for the patient to see later. Sometimes it's helpful if you're doing some documenting, how many stitches did we put in, you know, exact location, things like that. So don't be afraid to take the picture. Review the pre-op instruction or the post-op instructions, even though they have them, even though you've mailed them out, even though we've gone over them with them, review them again. Sleeping position is important. Unless it's, you know, on a foot or a hand, you're going to encourage them to sleep sitting upright. All of that's in the post-op, but just remind them. And then always ask them, do you have any questions? They will, they may not, but always ask them as you're going out the door. Girls went over the fully stocked goodie bag. Don't be afraid to put too much in there. You know, if we have specifically told the patient, I want you to ice this every, 20 minutes every hour, give them 2 or 3 ice packs. You know, that way they've got one ready to go. They appreciate that. Some things to remember, just some quirky little things. Doctor has the right to change his mind, and he will. Just roll with it. Invariably, you will have the light just perfect. He will walk in and he will adjust it. That's his right. He's the surgeon. He loves to teach. So he likes a quiet OR, but he loves to teach. So, you know, if you see him doing something and you kind of sense that it might be a good time to ask him, why are you doing it that way? He loves to be asked, is there anything I can do to make it better? You know, for next time, would you like me to do something differently? We're always changing. We change, you know, sometimes day to day with our Mohs, we change how we do things, so we just roll with it. If you don't know how to do something, or you don't know how doctor or I want it done, don't assume. Ask me. If you're afraid to approach doctor, ask me. We work together so long I can kind of anticipate what he wants and what he doesn't want. But don't just assume you know what we want and you just do it, because then we're working backwards to try to correct that. So, and then the other big stickler is, unless it's in the direct field, don't worry about the mess. You know, things get messy. Faces, scalps, they bleed a lot. There's going to be a lot of blood. It's going to collect under the patient's neck. Don't clean it up. Your focus has got to be on the field of the defect. And unless you are absolutely certain that you can get in and out with your sponge, wait until he asks for you to clean something up. And he'll tell you, he'll be very vocal about, okay, sponge this. But again, we've seen some hands pushed away because he's got to focus on that. And if we have hands coming into that field, you're going to get poked. Yeah, so just stay out. And then also a really important thing is the patients are medicated. They absolutely cannot drive themselves home. If they just absolutely say, I do not have anybody to come get me, their option is we can call a cab, Uber, Lyft, we can call a friend, we can call the Medivan, or their other option is to sit here for 3 to 4 hours until their medication is worn off. I try to remind them not to drink any alcohol that day because it is a anti-anxiety medication that we give them. I also tell them the next day they may still feel a little groggy, and if they choose to drive and ignore instructions, they can get arrested for a DUI, driving under the influence with the medication, so we try to remind them that. Even though they say they're fine, when you get them off the table, walk with them to the waiting room and kind of verify that their ride is there, or you know, if they're going to sit and wait, that's fine. Always offer them the wheelchair, and even if they're saying no but they're a little wobbly, put them in the chair. We'd rather get them out of the chair than up off the floor. So that's a typical Mohs day. That's a little background on Mohs, a little education on why we do the things we do, and